Well, let me start by asking you, Dr. Goldfinger, tell us what is the definition of infant mental health? And again, if you're like me, you think infants 0 to 12 months, but that's really not what we're talking about here. Tell us a little bit more.
Yeah, so generally speaking, like you said, most people think of infants in general, we know, are in the age 0 to 12 months. So when we think of mental health, we don't necessarily think of the needs of babies, right? But 0 to 3 and many organizations and experts that have looked into this over time have created a definition, and I'm actually going to read it to you since I don't want to get it wrong, and it's got a lot of really powerful aspects to it. So we've actually expanded this to be what's called infant and early childhood mental health. So it's not just about the first year of life. And it is defined as a child's capacity to experience, manage, and express a full range of positive and negative emotions, develop close, satisfying relationships with others, and actively explore environments and learn, all in the context of family, culture, and community. So if you notice, there are a lot of things there that don't really sound like a disorder. In fact, the most important aspect of this, from my perspective as a general pediatrician and 0 to 3, is that this is actually synonymous with what many people call the social emotional development of the child, that infant mental health is a healthy, natural state and something we want from the outset to protect. And it isn't necessarily just about identifying disorders. And it's not only that we want to protect, but we want to prevent those disorders, and we want to promote that developmental, mental, or social emotional health for children.
Fantastic. So it's really about how do we proactively engage with our infants and young children so that their brains develop in a healthy way and emotionally they develop in a healthy way.
Absolutely, and I would just add engaging with the parents, because as was stated, no infants walk into the clinic. So
Sounds right.
in infant mental health, and what's obviously very relevant for what we've been hearing about today, is inextricably tied to the mental health and other needs of the parents, especially the mothers. And so while that definition really does focus on the child, we can't get away from that their first teacher and first nurturer is going to be their parent or caregiver, biological or other.
Perfect. Thank you so much. Dr. Ippen, let's move on to you. We heard, I think, in your bio, and I know I am aware that your foundations, you and Dr. Wisner, are actually flipped. Dr. Wisner started in infant mental health and then moved into maternal mental health, and you actually started in maternal mental health and treating mothers and became engaged in moving to the infant mental health field. Tell us a little bit about your work in maternal mental health, if you don't mind, and how they relate. We've heard a little bit from Jonathan, but tell us more about what you think.
Sure. I mean, actually, I did start in infant mental health.
Oh, you did?
Well, yes. So I started in Mary Mann's lab, really looking at attachment, even when I was an undergraduate. And then in graduate school, I ended up with Ricardo Munoz on a program called Proyecto de Mamás y Bebés, which is the Mothers and Babies program, which is a depression prevention treatment program. I was there on the ground floor when we were trying to write a manualized kind of 16-session intervention for mothers and their babies. And so I was part of the development team for that. And I think one thing that was really, so we were combining cognitive behavioral therapies with interpersonal psychotherapy for depression. One thing that was really fascinating also in leading the groups was how much of when the mothers were pregnant and when they were depressed, these were mostly immigrant mothers, for many of them, how much they were thinking about difficult things that they'd experienced and fears that they had related to their babies. And that it was really, for me, the intersection of depression and trauma. And, also thinking about immigration-related trauma, sociocultural trauma, as well as past family trauma that they were carrying. And really needing to look both at, I think I really do love the SAMHSA catchphrase of it's not what's wrong with you, it's what happened to you. And do you have a place where you can discuss this because they were depressed for a reason, for what they were going through. And yet many of them did. Many of the women that I worked with in clinics did have an endogenous depression that did kind of limit both their ability to connect with their baby as well as affect their self-concept. And so it being really critical to work 2 generationally. And that's really what also propelled me to go back and start working with infants and young children with Alicia Lieberman at the Child Trauma Research Program. I think really holding both kind of, I think, two key phrases from our field. One is Winnicott's phrase, which is there is no such thing as a baby, right? So that babies are always seen in the context of their caregiving relationships. And so we don't treat babies, we don't put babies on couches. We think about kind of how, how we work in partnership. And if the caregiver is struggling for some reason, then that becomes a part of what we do, is to support the caregivers so that they can support the children. The other sort of key phrase that I hold dear to my heart is really from Selma Freiberg, one of the founders of our field of infant mental health. Selma Freiberg wrote a brilliant article called Ghosts in the Nursery, and if you haven't read it, you should read it. But it's really about how the transition, we think about becoming a parent as a developmental stage, and that there is no time when your childhood becomes more alive for you than when you become a parent. That if, sometimes it's beautiful, positive memories, but other times it's memories of difficult things. And oftentimes it's when you're pregnant, for many of the women, that they start to think about things that they've been through. They may have fears about, am I competent? They may have fears about what does this child represent, along with joys. But I think we need to be able to talk about both of those things, and that they affect the family as well as the child. And I also don't want to leave fathers out of this, because I think too often in our field we have, and really thinking, but it's a developmental transition for them as well, where fathers are also thinking about kind of their own childhoods and what kind of parent they want to be. And so I think it just becomes critical to work across generations, and sometimes with grandparents as well in our work.
Great, thank you for that. I want to pause for just a moment on this concept of trauma. We talk often about traumatic experiences. We know that women who have suffered a traumatic experience may have a difficult time during pregnancy or childbirth, thinking back to that traumatic experience. And we know that young children, babies who have a mother or a parent who have suffered from a mental health disorder during the perinatal period, that can be traumatic for the infant too. Anything else we should be thinking about relative to trauma in this relationship?
Oh my goodness, so much.
How much time do we have? More specifically, are there?
Let's move on to another question. But I think I recapped maybe a little bit about what you said, and if I didn't, feel free to add. But we'll get to some more in just a moment. Let's hear from you, Chandra, about interactions that mothers can take to help improve infant mental health, or parents can take. So what are some tangible things that people in the room with infants or friends, they have friends with infants, can do, especially if they may be depressed?
Yeah, I wanted to sort of also digest a little bit of the question that you asked me, because
Sure.
It was so big, and I think that this is a related answer to that question. So I guess what I was thinking, this is a weird way to answer your question.
That's okay, we like that.
All right, so for example, when we hear a baby's cries, right, we are all programmed, hopefully, genetically, to want to respond to the baby, right? And that's sort of what keeps our species safe, is that we go and we take care of the baby. What is interesting is that for some people who have histories of trauma, for example, what we've seen is that when they hear a baby's cries, something different happens inside their bodies. And they've done studies where they have, this is the weird part, where they have put mothers in MRI machines, and they have had them listen to both their children's cries as well as the cries of a baby that is not theirs. And what they see is that mothers who have a history, who have PTSD, that they respond differently, that they are more aroused. And so I think about it as the cries of the baby have a different meaning, and the cries of the baby may actually be more toxic to certain people, if that makes sense. And so if I'm looking at this mother and thinking, well, why is she not responding to the baby if I'm intervening? The thing is, that's an excellent question, right? And I should probably breathe and think, well, why is she not responding to the baby? Because invariably there's a beautiful story there, and that sometimes that story is not fully accessible to her. and that I think that she may really actually think, why am I not responding to the baby? Is there something wrong? So I think the first thing that you can do if you're a caregiver or somebody is going through this or you're going through this is to respond with compassion and benevolence and to really understand that there is a reason, because I think we really do believe in our field that we have to support caregivers so that they can support children. And so it begins from a foundation of understanding that there is probably a reason for why. The other thing that I often tell people, and I do a lot of my work in Spanish, so it's really hard for me not to do this work, but just to think about how, in Spanish I say that mothers are like trees. And that often that we care for the fruit because, in Spanish it's easy to say, para que la fruta sea dulce y suave. So the fruit is, sort of sweet. But in order to do that, we have to actually take care of ourselves, right? And so I think hay que regar agua a la planta para que la fruta sea dulce y suave. So we have to take, so I think allowing yourself to receive help and support is really key. And in a lot of the women that I see, they'll come in for the children, but they won't come in for themselves. And I think that that is foundational, that you come in for yourself. So I know that sometimes I am kind of the first contact that they'll have to get mental health services for themselves. And then equally, it's a two-generational thing, because even as we're just serving women, what we're often seeing is that there is a baby there. And we need to think about what is the safety net? How severe is the depression? Because if you have a severe endogenous depression, you really do need support. And I just want to say that, if you had cancer, and something was happening, you would be saying, who is going to help my baby? Because my baby needs to connect with somebody. It's not my fault. And yet with mental health disorders, we tend to think, kind of what is wrong with this mother? Why can't she do this, or this father? And we really need this team approach where we're not blaming individual people. And then we do need to realize that why is it that this mom's not connecting to this baby? What in her history? How do we attend to that? And then how do we support them in connecting and having that relationship? A lot of times, how do we notice the little strengths that she's doing anyway? Because there are these beautiful moments of connection. I think about, floor time. I think about Watch, Wait, and Wonder. We have beautiful interventions really designed to kind of strengthen the caregiver-child relationship, the baby relationship, by noticing, what is already there, HealthySteps, by noticing the strengths and building on that. And I think when they're not there, oftentimes it's critical that we go deeper.
Great. I heard a couple really great quotes, so I hope people are tweeting and putting these great things on social media for us. And there will be a prize for someone who's not on our team who has some great quotes up. We'll surprise you. Thank you for that. And I think we heard not only this beautiful quote about fruits from the tree and taking care of the trunk and watering the tree, but a little bit about, maybe faking it till you make it and respond with compassion and smile and floor time and interacting. Let's move on. You also said something to the effect of a lot of moms perhaps who are not suffering from, or are suffering from depression, may not go in for help for themselves, but will go in for help for their babies, right? We know this is the case. I'd love to hear from you, Dr. Goldfinger, about, what's the role of the pediatrician and other providers who are infant mental health specialists, and again, just anything you want to share about the role of providers and pediatricians.
Sure thing. So the first thing I would say is that most pediatricians are not infant mental health specialists, so it's important to recognize where the gap is in terms of their education and their capacity to manage all of this on their own. What's extremely powerful about pediatrics, we know, is it's the one place that all parents in America go with their babies, especially their newborns and their infants. There's almost nowhere else that you can connect with families so consistently, which makes it a very powerful opportunity to engage families, and why we at 0 to 3 are thrilled that the HealthySteps model that Dr. Ghosh Ippen mentioned is actually now a program of 0 to 3. And this is a program where we recognize those challenges that providers may have, and we embed child development and family development specialists to really support and hold the caregivers. But we do know that the American Academy of Pediatrics, the National Academies for Medicine and Sciences, formerly the Institutes of Medicine, ACOG, right? Pretty much every society recommends universal screening for maternal depression and now also infant, what we would call social emotional development. The question is whether pediatricians in America are doing that. And I'm actually fortunate to sit on the AAP's board, National Advisory Board, for a new initiative to look at screening and practices and how we can develop a new model nationally for ensuring not just screening, but the intervention, the discussion with the parent, the promotional guidance, the positive parenting guidance we can offer, and the connection to critical resources, including infant mental health specialists and maternal mental health professionals in the community. So we know that screening rates, when it's not a big focal point of the education, there are policy issues there are financial issues there in terms of what's paid for by payers, wink, wink. And we're big fans of Cigna and all that you do. So I think it's very important to recognize that we have to think about this in the context of the community and society and what we do with the policy in our society to ensure that every mother is screened for maternal depression and anxiety, which is so frequently really the underlying, one of the comorbidities, and every child is screened for the challenge to attachment that therefore is a risk to their development as well. And so we're really working on pediatricians improving. We have a lot to do. Unfortunately, we have models, and we have infant mental health specialists. So infant mental health specialists across the United States range. There are people who that's their focus, and traditionally the field had mostly medical, psychology, psychiatry, social workers in that role. And now we're seeing a broader array of professionals like licensed marriage and family therapists, other licensed consultants, and even occupational therapists going into this. And there's a growing, still few, but a growing number of universities that are offering certificates, both for specialists who can actually not only identify and diagnose, but treat, but also for other professionals who might work with young children and their families to even be able to start that screening and perhaps some amount of intervention, because we know that there probably is a workforce shortage in terms of the number of infant mental health specialists like Dr. Ippen. So it's very important that we kind of maximize how primary care professionals, how early child care and education professionals do this. And at 0 to 3, we also have a number of other developing or recently developed resources. We have, some of you may be familiar with the cross-sector competencies, which focus on 8 domains of how all professionals that touch the lives of young children and parents can learn to communicate and effectively engage families. That was funded by First 5 Los Angeles right here.
Great.
So that's one opportunity for additional professional development, including online modules. You can basically take an hour of your time, or it's probably 8 hours, to learn about how to focus on child development in relationship-based approaches, in terms of family-centered care, and in terms of the team. One of the things I think is most important is recently recognized by the AAP and others that this is not any one professional's responsibility. This is all of our responsibility, and we need to learn as professionals that serve families, especially women and children, how do we work better together to provide that holistic or comprehensive wraparound support in this critical period.
Great. I heard a couple things, and you probably did too. The first thing that I wanted to recap on is it does seem like there's a lot of similarities, doesn't it, with infant mental health and screening, and that not all pediatricians, for example, are screening for infant mental health challenges, just like we know in the field of maternal mental health, very few women are being routinely screened. And so for me, this idea of measurement, which we'll talk about in a little bit today, sort of how do we measure screening rates and report them to the public and others, and find ourselves developing interventions around the needs that pediatricians or OBGYNs, for example, need to improve their screening rates, that screening measurement is critical. I had one more thought, and I think I've lost it. But that was really helpful. And I guess we also, in our field, the similarities here is that we have declared our field, starting here in California, but others too, including the American College of Obstetrics and Gynecology, that OBGYNs have to be the home base for screening and detection of maternal mental health disorders, starting in pregnancy, hopefully having a conversation about risk factors before that. But there is a no wrong door approach. I think you said it really is a collaborative approach to wraparound services and make sure that we're all prepared to catch moms. The other thing I was thinking of is if I were a therapist in this room or watching right now, I would be excited to think about maybe getting a certificate in infant mental health so that I could help bridge that work for my moms in treatment. And so I wonder if others got excited about that too. Let's move on to Dr. Ippen, and I'd love to hear you talk just a little bit more about attachment. What is attachment? Why is it so important? I think we heard a little bit about infant brain development earlier, but tell us a little bit more about attachment.
Sure. I think fundamentally, attachment is about safety. And so really the idea, and it's hard for me to explain without drawings or actions. So if I believe that you keep me safe and like you're my attachment figure, what that means is I can go off and I can explore the world and I can learn and grow. And that when I need to kind of recharge, I can come right back to you. But if for some reason I'm looking at you and I'm not really sure, I'm not sure either perhaps because you might be a source of fear or because I fear that you're not available, then that's going to affect the way that I explore the world. And we can see different patterns, perhaps due in part due to who the child is kind of genetically, where I might be very clingy. So I might sort of be like, I'm not sure if I can leave you because when I look at you, you're not really quite solid to me. And so I'm going to hang out with you. Or I might think, well, actually, I'm not sure if I can count on you, but maybe I'm going to be reckless, perhaps in an effort to say, will you come get me? Or maybe I'll go off with others because I am looking for sort of a source of a safe base from which to explore. And this is really fundamentally, I think, about kind of evolutionarily, kind of how we grew to sort of, the young have to be protected. And when we're protected, we can best learn. That make sense?
Beautiful, and I think about our low-income communities and parents who are struggling because they're working, 2 jobs or multiple factors may be at play, and that maybe it isn't safe because a mom or a parent isn't available in those families. Do you have thoughts on that? Things that you can share relative to low-income populations?
Yeah, I want to start by saying that I've seen tremendous amounts of strengths in low-income populations. And I think that many people do have to work multiple jobs and do manage to create loving relationships. And I think the quality of care that they get when they're not with their caregivers, whether it's a grandparent, I think we're seeing that children can have multiple attachment relationships is really critical. I also think it's critical to think about in a lot of families, there are stressors related to poverty, there are stressors related to community violence, and there are stressors related to violence in the family. I worked in Los Angeles. I did my graduate work in Los Angeles. There are Head Starts where the rates of trauma exposure are about 90%. 90% in terms of community violence. In the United States, we have a 20% domestic violence prevalence rate, and that's cutting across socioeconomic status. And so when I say this, the reason is if we think about attachment as being fundamentally about fear and safety, when those things are happening, how does that affect the parent's sense of fear and safety? And how would that affect any of our abilities to feel like we're a good, safe base? Sort of like if the hands that hold you are trembling, then it's hard, and we have to really help the hands that hold you. And I think that that's really critical, and I think it's critical in low-income populations because what we know is that unfortunately poverty is associated with other adverse experiences. But I don't think it's unique to folks who are poor. I think that's something that we really have to see is that we have to open the door to talking, and I know that we're talking about the critical importance of depression, and that was something that I've really been involved in is thinking about depression screening with Ricardo Munoz and different ways to do it. We also need to look at, given the prevalence of traumatic exposures, the importance of screening there as well, because they're so linked. Depression and trauma are inextricably linked within our society.
Let's come back to that in just a moment, screening for trauma and what that might look like. I want to ask, I think a lot of women who have suffered from a maternal mental health disorder may have had a difficult infant. Sort of, we talk about a baby just coming out and being difficult out of the chute, whether it be colic, just sort of self-regulation issues. What should we be thinking about relative to infant mental health and interventions? You know, are there some things that you have thoughts on relative to mitigating those challenges? And this is a question that was not on our approved list of questions.
That's okay.
So I'm throwing in some new ones here.
So first of all, we know that not all infants come out. We tend not to think of it in terms of whether they're difficult from the clinical perspective, but more in terms of their temperament.
Yes.
So we know that there are temperament mismatches between children and their parents, and that's actually very common. And we shouldn't think that the mother or the father or other caregiver who struggles and feels the child is difficult is anything but just a mismatch. You know, you can have children that are very, very clingy and loving and, you know, and so lovable, and the parent isn't ready for that. Or you can have babies that are super, you know, crying and needy and waking up more times at night, and the parent isn't ready for that. So it isn't just mothers with a diagnosed mental health disorder, but across the board there's significant mismatch. And we think that the repair of that mismatch, we talk about as a mismatch and repair, is one of the critical aspects of building secure attachment. And so the ability to acknowledge, to identify when there's a mismatch between temperament with parents, and to help parents see that, because they don't often think of it that way, is important. It's also important, as was mentioned, to focus on strengths. We really have to get away from this issue of thinking of it as all a diagnosed or diagnosable disorder, because there's an array of normal challenges that parents face. And while we're thinking of mental health and we think of it in terms of a promotional and preventive context, we can prevent a lot of these mismatches turning into the trigger for, right, the mental health diagnosis or the mental health predisposition a mother has, right, in advance. So if we were to spend more time educating women, and we think about this construct as the super mom, right, especially nowadays with social media, how many women are online hearing and seeing only about the great things that moms do with their children? How many of them say, last night my baby was up and I wanted to, you know? They don't say that, right? They say, well, you know, we're doing so great and going to this mommy and me, which is good. We want to focus on the great things they do too, but in our society, we have to get away from this notion that there's the perfect mom or dad. That really doesn't exist. There are all of us, mothers and fathers, learning to repair and be connected to our children as best we can. We will all have those episodes where we don't match perfectly with our children. Anybody with teenagers knows it may get worse, right? And so over time, we have to really stop thinking of it as bad child, bad parent. And I challenge that construct. It's more child and parent who might not be on the same page right now. And this is where infant mental health specialists and other professionals can really help parents see it like that and focus on the child's strengths. So when the child is crying all night, you know, we might want to focus on how cute they are. And people always say, right, that's why God made babies cute. So in the middle of the night, you tolerate it, right? But being able to help parents focus on their baby's strengths and the positive experiences that they have is equally as important as you know, diagnosing or acknowledging those difficult mismatches.
That's great. I haven't heard that term mismatch much before, and I don't know if others have. That's good. Thank you for introducing me to that concept. I know that our team would likely, is that better? Our team would likely be waving or kicking me under the table to say, don't forget to talk about the social media campaign during Maternal Mental Health Awareness Week, the first week of May, and the theme is real motherhood. And the challenge is to talk that week as mothers, whether we have grown kids or infants, to just talk about the challenges of motherhood. And so thank you for that and bringing up you know, those challenges around social media and keeping it real. There's also this idea, right, that we're not raising our kids in villages anymore. And so many parents may have false expectations about how difficult it is to raise an infant because we just haven't done it, right? Haven't babysat, for example, since we were 16. So thank you for helping us think about that. Let's go back to Dr. Ippen, and we'd just love for you to touch on cultural considerations. What else do we need to think about from a cultural perspective?
This could go on for a long time, but I'll give you a few.
Can we hear Dr. Ippen okay?
Can you hear me okay?
Oh, maybe.
How about this?
Yeah, that works.
All right. So I think as you become a mom or a dad and you start thinking about kind of how you want to raise your child, you're going to socialize them according to your culture. But I also think about that transition to pregnancy. There are all these rituals that you might have that are connected. So for example, with a lot of people from Central America, from Mexico, from other places, there's the practice of la cuarentena, 40 days after the birth of a child, that you're really going to install yourself, you're going to get love and support and care. There's a very similar tradition in Southeast Asian cultures, just for starting to think about just that postpartum period. And what does it mean if you're an immigrant mother? What does it mean if you have lost that? How do you think about that with somebody? That kind of loss of your traditional cultures and rituals, and how that can actually predispose you to depression. So that would be one thing that I would think about. And then even as we think about raising our young infants, there's been a ton of studies that suggest that kind of simple things like, do we want our child to eat independently? Do we want them to feed themselves? Or do we really want to feed them? So even as we're coming in as infant mental health practitioners, we often have a lens that has been shaped by our views, right? We're actually part of a culture. We're part of a culture of infant mental health. So I like to tell people that we have really bizarre beliefs, like that parents should follow their children's play, and that it's really good to label all your feelings. Now, these are beliefs that I hold because I've been socialized by them, but they're not beliefs that come from my traditional culture, which I'm half Japanese and half East Indian, raised by immigrant parents. And so I think we always have a cross-cultural dialogue with families about what do they want their child to learn. If I'm really thinking about emotions, what do they want their child to learn about anger? Why might they want their child to learn this about anger? What is their larger current sociocultural context and the way that given this family's race, ethnicity, that they are responded to by the larger society that affects the way that they need to socialize their child about anger? And so I think the critical thing here is that I can't go based on my assumptions. That I really need to open the door to talking about all of this, to talking about what your culture means to you, what it means in terms of your rituals and practices, what it means in terms of the way that you raise your child. That's a critical dialogue that we often don't go into, but when you do, it's very rich.
Great.
If I could just add quickly in terms of both a personal anecdote and I think what the implications for our broader society and culture. So personally, my wife is Iranian. Okay, so our kids, and I'm on one side, many generations American, via Eastern Europe on the other. And so our kids love crispy rice and hot dogs. But at the same time, there are major cultural differences between how or whether you should let your child cry, ever. So there can also be a mismatch in the parents and the caregivers. We know this from research about when grandparents step in, they may have a real difference of opinion in terms of child rearing, and that's critical to be able to navigate that as a professional and help identify the strengths and the common ground for different caregivers. And I would say on a policy level, we shouldn't forget as well the critical missing piece in terms of paid family leave in America. We cannot expect people to have the bandwidth to bond with their children and repair some of these mismatches or seek the help they need if we're not actually supporting mothers and fathers and other caregivers to be home with their children. For so many cultures,
I think we should clap for that.
Possible.
Yeah.
So call your congressman or woman, please. Tweet them, talk to them. Bills are going through Congress now to talk about this, and you can see the hashtag. I forget what it is. Sorry, 0 to 3, but we talk and we tweet about paid family leave. It's a critical piece here in this modern melting pot culture we have.
That's fantastic. It's also one of 2020 Mom's federal policy platforms, so we'll make sure you get information on paid family leave That was really helpful. I'm going to plant a question that is a new one again in you, and then we're going to go back to Dr. Ippen after I share this question to talk about screening for trauma. Dr. Goldfinger, tell us a little bit, if you could ask institutions, so hospitals, maybe clinics and insurers, for example, payers, to do one or two things each. I'm giving you a lot to think about. That's why I'm going to plant the seed now, or one thing each, or you can just hit on one of those things. But like, if you could say one thing needs to happen to make sure moms and babies thrive.
It's my birthday, right? Like
yeah, this is a happy birthday present. That's right. That's right. We'll come back to that. And Dr. Ippen, let's talk a little bit about screening for trauma.
So what would you like to know?
How do you do it?
So one is, it's really not just about checking a box. It's about having a dialogue with somebody where they can think about what have I been through and how might it affect what's going to happen. So for example, we have a treatment called child-parent psychotherapy, and many of my colleagues are really working, they've developed perinatal child-parent psychotherapy. And when we think about this, how would we open a door to a woman to talk about perhaps a history of sexual abuse, right? And how it might affect what it's like to give birth for her, how she might want her birth plan done so that she has more control over her body. How would we let her talk about that when she's coming to breastfeed? Because depending on what your history is, that could be quite traumatic. Does that make sense? Mm-hmm. We think about, and many of the questionnaires that we already have in existence, such as the SWIC, there are items on there, which is used commonly in sort of pediatric practice, there are items on there that ask about parent conflict. So conflict between partners, right? And it's interesting because right shortly after you have a baby, you're not sleeping so well. So it's actually quite natural to have some conflict. And so it's quite natural for pediatricians to feel comfortable talking about sort of how are things going within your partner relationship. If people say there's absolutely no problems, well, that's generally interesting. And so many pediatricians, they use that to open the door to kind of, what is the child, what is going on for them, what are they being exposed to, and then there's really more formal screening. Where we get trained, but it's not just that we're trained to like ask you a bunch of questions looking down like this, but we're really trained to help you to feel safe, knowing that you may not actually answer them because I am part of a system where if you're talking about these things, we're part of a system that sometimes removes children. But how can I talk about it in the fact that this happens to a lot of people? And I think what we need to also recognize is that the number one time when domestic violence starts is during pregnancy. And that the prevalence of this is so high that, we encourage pediatricians to talk about smoking. So equally, we need to encourage pediatricians, OBGYNs, everybody to get comfortable talking about this.
That's great. Thank you so much. We're going to turn it back to the birthday boy. And also, I did want to say, did the rest of you also think to yourself, oh, good, a pediatrician's giving their kids hot dogs? Because I know I had that thought for just a moment. Keeping it real, right? Real fatherhood, real. Carbs. Yeah, and fried carbs. Oh yes, good. Don't forget those. Good.
To my wife's chagrin. So the two questions. So these are based on my personal and clinical, my clinical and professional experience. The first question would be a real clinical question, which is, what are health systems doing to utilize already proven models, team-based care models of support for children and families that we know work? I think we're well past the time of researching what works in terms of addressing many of these issues and how to make it work. The question is, what are they doing to look at their care models in the prenatal space, in the pediatric space, and say, do we have the right team members there when the family needs them? And are they doing it in the appropriate way, in the proven way? The good example is HealthySteps is a 22-year-old model, and only 74 practices in America did it when it came to 0 to 3 2 years ago. I'm proud to say, working on it, we're now in 124 practices within 2 years. So we're growing rapidly, and philanthropy has jumped in. We recently secured a $39 million investment to scale that type of integrated behavioral health care in pediatrics across America. We're hoping to reach 1 million children by 2032. So I would ask the health systems, what are you doing, and how can you partner and invest in it? And in terms of the second question, I would ask health systems, especially those who take on financial risk, and payers, what are you doing to pay for it? Because we know that we're saving you money with these types of services. There's really no question about it. Study after study after study has shown that these kinds of supports, whether it's breastfeeding, mental health, infant and early childhood mental health for parents, these types of teams still save you money. Even if you have to get added professionals involved, the long-term gains financially are there. So what are the payers and health systems doing to align payment? And I know you guys are. Align payment so that we're actually paying for those cost savings and those critical outcomes for children and families.
That's great. So on that note, employers, others, payers, we need to take a closer look at this. Let's give a round of applause to our two panelists and say thank you.